everybody hear me okay? Sounds like it. Yes, wait. Hello, yes. Thank you, Gordon. All right. Cool. So I was invited to talk about pacemakers. I appreciate the opportunity. I'll caveat everything with, though, yes, I'm one of the cardiology fellows, I will not pretend to know everything. So if I don't know the answer to one of your guys' questions, I apologize in advance. I will look it up and I will get back to you as soon as I can with an email to the chief so that they can email out any responses that I miss or anything that comes up. But we will go through this and hopefully it's educational for you guys. All right, let's see here. There we go. So when we're thinking about pacemakers, before we go into the modes and all those fun things, it's important to remember the indications. So kind of the big picture indications are to relieve or prevent symptomatic bradycardia. And I think everybody kind of knows this, especially when they're talking to the consult team. What we really are looking for is symptomatic bradycardia. And assessing symptoms can be a little bit challenging. Especially because in correlating symptoms to bradycardia. So that gets to point number two. So asymptomatic bradycardia and serious symptoms consistent with bradycardia, but we haven't been able to correlate the two. And that's another one of those indications that's reflected in our guidelines. And then there are some patients that we'll do some pacing for if we know that their underlying pathology puts them at high risk for bradycardia. So our infiltrative cardiomyopathies like sarcoidosis, those are patients that sometimes we'll put pacing devices in prior to the development of any symptoms because we know that the natural history of their disease process will lead to bradyarrhythmias. So this is a very busy slide, and we're not going to obviously go through all of these things, but it is a summary slide of the indications for cardiac pacing. And I'll share my PowerPoint with the chiefs as well, so you guys have this. But you can see that there's a lot of different ones. And they're divided up into class 1, 2. Um, and we'll go through a little bit of these things and how pacing modes can address some of these issues. But you'll notice the far left column there, sinus node dysfunction, acquired AV block, which we'll talk more about soon. And just as busy as that previous slide is, so are the number of guidelines that cardiology puts out, as you guys are well aware. And it's really to our own default. We like trials, we like guidelines, and it can be confusing at times. If I worked with any of you guys on consults, like I know Gordon and I have, and some other people that are logged in, I always like to refer people to the ACC's clinical guideline app. It has a full section on device-based therapies right there, DBT, and it can be a helpful tool for you guys when you're talking to our consult team about, hey, I think that my patient fits into this category, and it would be a class 1 based upon my interpretation. So I highly recommend this app for all of you guys. It can be a very helpful app for all things cardiology. So let's quickly review the normal intracardiac conduction system. So as all of you guys know, normal conduction will start in a kind of a stripe of cells called the sinoatrial node. And from there, it will kind of travel through the right to left atrium. It connects over to the left through Bachman's bundle. And ultimately, it ends up in the AV node, where it'll hang out for a while before piercing through that fibrous capsule, separating your atria from your ventricle, called the His bundle. Once you've gone through your His bundle, it splits into the right bundle and the left bundle, and then the left bundle splits into two fascicles, the anterior fascicle and the posterior fascicle. That's kind of general layout. It's important to keep in mind kind of your anatomy here before we jump to pacing modes. So let's talk quickly about what's the components of a pacemaker. So the first one are your leads, and you've got generators. Those are two different pieces. Your lead is it consists of a small distal tip electrode that has the capability of pacing and or sensing. So this is kind of the end of a lead here. This little part here has the ability to pace or sense. Usually they will have a fixation mechanism associated with it. That's a little corkscrew here. That is not your temporary pacemakers. Those are the ones that kind of free float in the RV. We try to get them down into one of the trabeculations. But for your permanent pacemakers, they're always going to have a fixation device at the very end of them. And that's also why it becomes very dangerous to pull them out because those fixation devices get fibrosed. So if you have somebody with endocarditis or something that you're worried about is infected, it becomes a high risk procedure trying to get these things out. The proximal terminal is connected to the generator. So your generator is over here. We'll talk a little bit more about that here shortly. And then you probably heard the term unipolar or bipolar leads. We'll talk a little bit more about this later. Basically, it has to do with the orientation of your anode and cathode. Um, Bipolar being that both components are down in the tip of your lead, unipolar being that is in the tip of your lead, the other one is up in your generator. And then when we get to generators, so a generator has two major components to it, the header and the can, or the titanium casing that it sits in. So the header is basically that top plastic component up here. It is where your proximal portion of your leads will attach into. And then the can is where your battery, all the capacitors, and circuitry are housed down in this bottom part of your generator. You'll hear new technology. So the world of electrophysiology is changing on a minute-by-minute basis. But we've come up with cool devices called leadless pacemakers. It's not really a leadless, it's just that the lead and the generator are housed into one piece of technology. So this is what a leadless pacemaker looks like. The most common one on the market right now is called Micra. Basically, it has these hooks on it, which are your fixation hooks. They kind of hang out in the right ventricle and hook onto some of the trabeculations of the right ventricle. It has the capability of sensing, pacing, and it houses its own battery and all the capacitors necessary for pacing. So you'll see more of those. We won't spend too much time talking about them. Our guys here don't really like using them a whole lot, but there's some very interesting things coming out about His bundle pacing using leadless. Ohio State is one of the places that just did the first one. So you'll see more and more of this as the field continues to develop. So there are some principles to pacing. The first one is your pacing and obviously your sensing. So your pacemaker senses intracardiac electrical signals. These are called electrograms, and then they detect or can deliver low voltage electrical stimuli called pulses, specifically when the intrinsic cardiac rate is slow. So the stimulation part, the pacing part. So how does it do this? So what it will do is it will deliver a local stimulus. It creates a field sufficient to depolarize the local myocardium, hopefully during diastole, to initiate a self-propagating wavefront, a depolarization. So you'll remember back to your physiology days where you have to have a meeting in a threshold for the sodium influx channels to open before a depolarization will happen. Well, this is basically delivering a stimulus to reach that potential to initiate a self-propagating wavefront. So when we talk about capturing, you'll hear that when we put our transvenous pacers in the CVI. That means that we're adequately capturing or stimulating the myocardium to create a wavefront. There's two components to this. So not only is it dependent on positioning, you also need to have a sufficient amount of energy and the duration of the energy that's being delivered. That's nitty gritty. I won't pretend like I know a lot of the details there, and certainly from an internal medicine standpoint, that is not something you guys need to worry too much about. Getting back to that bipolar versus unipolar, so the tip of the lead is always going to be your cathode. The anode is either going to be within the lead itself, that's your bipolar lead, or it's going to be housed up in your generator, and that's your unipolar lead. So it all has to do with where that anode is. From your guys' perspective, it really doesn't make a ton of difference. We're using mostly bipolar leads now. I see a question here. What do you mean by the local stimulus? So what I mean by that is you're delivering a voltage to the tip of your lead there. So that's the local stimulus. You're delivering energy, and you want a sufficient amount of energy to create, to meet that threshold to open the sodium channels and ultimately allow a wavefront of just like you would from your normal conduction. Krista, did that answer your question? we'll move on and then, yeah, okay, cool. All right, cool. And then the second component to this is your sensing. So an electrogram, we see these EGMs when we interrogate a pacemaker. It is basically the difference between 2 points in space as a function of time. And this is done down at the end of your lead. And it picks up all electrical activity that that lead is sensing. As you can imagine, and I'll pose this question to you guys, what potentially would be the problem with this model? If you guys want to try to answer that, and I'll kind of move on, and I think it'll become a little bit more clear. So if you're sensing all electrical activity into the lead, this becomes a big problem because there's more than just your heart that's creating an electrical current, and specifically there's more than just the ventricle or the atrium that you're sensing that's creating electrical current. So for example, if you have a lead that's sitting in the atrium, that atrial lead is also sensing ventricular depolarization. It's also sensing the pectoralis muscles depolarizing. This becomes a problem because you don't want to oversense all the things that are not related to the chamber you are sensing. So we try to filter this out and we created an amplifier threshold to try to see what is a truly sensed rhythm versus something that is not truly sensed. And this becomes really important. Like, for example, you know that when we go to the OR, we always get called by the surgeons to try to help with the pacemaker because the electric cautery that they're using in the OR can actually be interpreted by the pacemaker as a sensed rhythm. And you certainly don't want your ICD to be sensing high frequency electrical activity because that can be interpreted as ventricular fibrillation and obviously deliver a shock, which you don't want. So how does this work? So the wave front is going to pass through the tip of your electrode. That EGM then travels from the lead tip to the generator. So you basically get your sensed activity here. It's conducted down to your generator, which is up here. It's then amplified, it's filtered, it's processed by the sensing electrodes, and then it's compared to your threshold voltage. So back here, we've set this threshold voltage, and then basically it's going to say, okay, is this sense activity meeting that sense threshold or not? And if it does, it'll interpret it as a true depolarization, whether it's atrial or ventricular, depending on what lead we're looking at. So that's kind of the outline of your pacers and basics of the electronics associated with them. We'll move on to how do you know what you're dealing with? You know, we frequently will ask on rounds, oh, what kind of pacemaker do they have? And one of the clues that can be helpful for you is to look at the chest X-ray, which we bring up on rounds frequently. So the first thing you can do is try to count how many leads are actually coming out of your generator here. So this is your pacemaker here. You see one lead. There's some coils behind it. All the extra part of your lead will wrap up and put behind their generator. But you can see one lead that's coming down here, and then it kind of terminates down in the apex of the right ventricle. So this would be a single lead pacemaker, as opposed to this one. So you can see that there's two leads leaving your generator. There's one terminating up in the right atrium, and then this one keeps on going out into the right ventricle. This does not necessarily mean that they are using both of those leads. So you can always program in whether or not you want to use those leads or not. So don't be fooled by that. When they're asking on rounds, what kind of pacemaker do they have, you can say, oh, they have a dual chamber, or they have a bi-V, but you really have to go into the settings to understand what you've told the pacemaker to do. So this would be a dual chamber pacemaker. You've got a right atrial lead here, a right ventricular lead here. And this is opposed to a biventricular pacing system. So again, we see three leads. They kind of overlap here, but once you get down into the SVC, you can see that these separate out. 1, 2, and 3. So this is your right atrial lead right here. This is your RV lead. And then when we're doing biventricular pacing, which we'll briefly mention later, what we do is we feed another pacing lead through the coronary sinus, and it weaves back here behind the LV, and you can actually pace from the coronary sinus. We'll talk a little more about bi-V pacing later in the talk. Any questions so far about that? And this is a trick question here, but obviously there's no can in the patient's chest, but it's always be mindful here. You can see that there's something odd down here. This is actually one of the micras, so it's sitting down here in the RV apex, clinging to one of the trabeculations. Again, this is going to be sensing only ventricular activity because you have nothing up in the atrium. It's only be able to pace the ventricle because you have nothing up in the atrium as well. Right. I don't see any questions coming through on the chat, which sounds good. We can keep going then. All right. So this gets us to our modes of pacing. So you'll hear a letter code. Typically, what we talk about on rounds is a four-letter code. There's actually five of them. And sometimes we even just refer to the first three letters. We'll talk about that here. So this is a kind of picture of your positioning of where in that code what we're referring to. So the first position is going to be which chamber is paced. So O means nothing's paced, meaning you're just sensing things. Um, A, if it starts with an A, that means that the atrium is being paced or has the potential to be paced. V means that there is potential for the ventricle to be paced. And D refers to you can pace both atrium and ventricle, depending on the conditions and the settings that you've set. The second position has to do similar to the first position, but it's which chamber is being sensed. And then the third position is what is the response that you want your pacemaker to do in the event that you've sensed a rhythm? So you want to inhibit activity or do you want to trigger activity? Or dual, you can do either one. The fourth position has to do with rate modulation. We'll talk a little bit about that when we get to the very end and we talk about, hey, what happens when somebody exercises? And then the fifth position, we rarely talk about this. It has to do with multi-site pacing. So, for example, your bi-V pacing, we have a denotation for your fifth position to help gear the person towards that there's multiple sites that are potentially paced. I would not worry about the fifth position. I don't even think an attending would honestly pimp you. All right, where's my mouse? There it is. All right. So before we talk about ways to pace somebody, it's important to remember that patients do better when we simulate your native conduction system. So I see a question here really quick. Does the response to a sensed rhythm change based on the rhythm detected? Let's see here. Does the response to a sensed rhythm change based on the rhythm detected? So no, and that is so that becomes a big problem, right? And that's how you can have an upper limit, and we'll talk about mode switching here in a little bit. But your pacemaker is not that smart, right? It's going to say, okay, I've been told to do a certain thing when I see something or don't see something. So it cannot tell you, hey, I see atrial fibrillation, I'm not going to conduct. Now you can set in there ways to mode switch, but it can't differentiate, hey, this is an SVT, we're going to do something different. It's not quite that smart. And you'll see that when we go through the modes of pacing. Does that answer your question, Danny? Cool. Okay, great. All right. So the concept of physiologic pacing comes in. So our goal when we are trying to design what somebody needs from a pacemaker standpoint is to try to simulate their normal cardiac behavior to the best of their ability. It's a fine balance because you don't want to put everybody in with multiple leads if you don't need them, but at the same time, we want to understand their disease and try to match the pacing equipment and programming to the underlying disease process. And that'll become a little bit more evident as we move through the types of modes. So trying to maintain AV synchrony, meaning that when the atrial kick happens, you follow that with a ventricular activity is an important component of physiologic pacing. Trying to allow for biventricular pacing if you know that RV pacing is going to be frequent. That's another way to maintain physiologic pacing. And rate responsiveness, another concept of, hey, when I'm exercising, is my pacemaker going to recognize that and appropriately increase my lower limit so that I can not pass out when I'm exercising? The benefit to this, so when you are simulating physiologic pacing, you're reducing the incidence of atrial tachyarrhythmias, including atrial fibrillation. Because there's less AFib, there is less risk of stroke and thromboembolic events. And then obviously there's improved hemodynamics when you're able to maintain your AV synchrony. As you remember, your atrial kick contributes at least 20% of your ventricular filling, sometimes more than that in patients who have a restrictive physiology or diastolic dysfunction. So when we're talking about pacing modes, I think the simplest way to think about it is single chamber pacing, meaning you only have one lead, dual chamber pacing, meaning you have two or more leads, or asynchronous pacing. We'll go through all of these here this afternoon. So we'll start with the simplest one, single chamber pacing. So the first one is VVI. So if you remember back to our nomenclature, that means that we have the capability of ventricular pacing, and it is going to be ventricular sensed rhythm. In the event that you sense a beat, you are going to inhibit the pacing activity. It's a very simple mode. Basically, you are just have a lead down in the ventricle, and you are just waiting for a ventricular activity. If you don't see it by a certain amount of time, you're going to deliver a pace beat. So you set a lower limit or a ventricular escape interval. That's that VEI up there. We actually in EP flip things around to a beats per minute to milliseconds per beat. So you are waiting a certain amount of time. If you don't see it, you deliver a pace beat. The advantages here, single lead. It's very easy to insert. An example of it would be your transvenous pacers that we do up on the floor or up in the ICU. The problem here is you don't have any atrial sensing, so you don't maintain your AV synchrony. Remember, you only have one lead, so there's nothing sitting up in the atrium to tell you, hey, the atria just went off, let's try to synchronize. You are just looking at the ventricle, and if the ventricle's too slow, you're going to deliver a ventricular beat. So the ideal patient here is somebody who has permanent atrial fibrillation or other patients where AV synchrony is not needed or is unable to be achieved. So for example, somebody with atrial fibrillation has a atrial rate of 350. You don't want to try to AV synchronize to them because that's essentially ventricular fibrillation. It's going to be V pacing at 350. So these are the good patients. If you're thinking about a long-term pacemaker, they have AFib, and have tachybrady syndrome. A VI pacer would be an appropriate pacing mode. All right. So similarly, we'll move on to AAI. So this is known as atrial demand pacing. Okay, so this means that your atrium is paced, your atrium is sensed, and in the setting of a sensed atrial activity, you are going to inhibit your atrial pacing. Again, also a very simple mode. It's predominantly for single chamber atrial pacing. We see this actually more in Europe than we do in the United States, and the reason is because if you have AV node dysfunction, go back to your picture of the conduction system, this is only going to be helpful for patients who have sinus node dysfunction. If you have AV node dysfunction, this becomes a problem because no matter how many times you atrially pace, if you can't conduct through your AV node, this setting can't do anything about it. So what you're going to do here is you're going to set a lower rate limit or an AEI, atrial escape interval. And again, similar to the VVI setting, if you don't sense an atrial activity, by the end of that terminal, you're going to deliver an atrial activity or atrial stimulus. The advantages here is that one, it's a single lead. The other one is that this one does maintain AV synchrony, right? So you're pacing your atrium. It's going through your normal conduction system. So your ventricle is going to be conducting in the setting of a healthy AV node to maintain your AV synchrony. The disadvantages here, so there's no protection from ventricular bradycardia. So again, if you develop 2-to-1 block, you don't have a way to actually keep your ventricular rate as fast as your atrial rate. So this is why it's very important if this is being considered for somebody to do an EP study on them to understand the health of your AV node because you're going to have to upgrade the system if you're set at AAI and you don't have a ventricular lead and develop AV block. The ideal patient here is going to be your patients with sinus node dysfunction, symptomatic sinus bradycardia, or sinus pauses. And again, as I've mentioned a couple times now, you have to have a healthy AV node or no evidence of AV block to do this. And then the other one here is ideally what you would have are patients who can accelerate their heart rate with exertion. Again, if you've got somebody with sinus node dysfunction whose heart rate is in the 40s, and you give them AAI with a backup rate of 50, and they go out and exercise, well, none of us like to exercise with a heart rate of 50. You need something to be able to augment the atrial activity, and whether that's the sinus node that can accommodate activity, or if it is a setting that we'll talk about later called rate responsiveness. Nevertheless, you have to decide if you want to turn that feature on or not to accommodate exertion. All right. So the next one, and the most common one that you're going to see up on the wards, is we've moved on now to your dual chamber pacing systems, is DDD. So this means that you have the sensing and pacing capabilities of both your atrium and your ventricle. We use this all the time. It is a very common pacing mode for your dual chamber pacemakers. And so I think probably the easiest thing to do would be to go through scenarios of how does this work and what do you expect your pacemaker to do. So if you have somebody who has a sinus rhythm where you are faster than your lower atrial rate and your AV conduction is normal, meaning that you are fast atrial rate, healthy AV node, and conducting one to one without any AV block, you're going to be completely inhibited, meaning your pacemaker is not going to be doing anything. So that's represented here in that first atrial beat. Your P wave presumably came on time. Your AV interval is with shorter than the set AV interval here, and your conduction goes straight through your His bundle down your left and right bundle, and there's completely inhibited pacemaker activity. The next situation is sinus bradycardia. So your atrial activity is slower than your preset limit, but you have normal AV conduction. So what does that mean? So that means that your interval between your P to P is longer than what you've set, but your AVI, your AV interval, is maintained. So in this situation, you're going to atrially pace, and this is going to be in this one right here. So you've waited the amount of time, you don't sense an atrial activity, you pace your atrium, and then you wait, and your AV interval is shorter than your preset value, and so you allow conduction to happen through your normal conduction system. Does that one make sense? So let's say that there's sinus bradycardia and you have AV conduction delay. So let's say you have a first degree AV block with a PR interval of 350, long PR interval. Well, that's not healthy either. So what's going to happen is this situation here. So you are waiting for atrial activity. You don't sense it within that amount of time. You're going to pace your atrium. You're then going to wait for your ventricular lead is going to wait for a sensed activity. And if you don't see it, you're going to pace your ventricle after that. So this maintains AV synchrony here, right? You've allowed for your ventricular filling from your atrial kick, and you didn't sense a ventricular activity, so you delivered one through V-sensed, or V-paced rhythm. Now, the other possibility is, let's say that your atrial activity is fine, but you have delayed AV conduction. So let's say, a heart rate of atrial rate of 70, but you have a delayed PR interval is again at 350. So and that's the last one here. So your atrial rate comes in before your interval is timed out. You allow for normal atrial activity, but your AV interval exceeds your preset limit, and so you deliver a ventricular paced beat. So this is really a dynamic system, right? And its goal is to maintain AV synchrony, and it's going to do that at all costs. So the ideal patient here is somebody who has AV block, who has normal sinus node dysfunction or has sinus node dysfunction and AV nodal dysfunction. So this really covers all of your pacing or your arrhythmias. If you're somebody who has slow sinus node, you have an atrial capability of pacing, you have diseased AV node, you have the ability to V-pace, and you're always going to try to maintain your AV synchrony. The problem then becomes when you develop an atrial tachyarrhythmia, because remember, this pacing mode is going to say, I'm going to maintain AV synchrony. That is my top priority. So if somebody goes into AFib with an atrial rate of 350, your ventricular lead is going to try to keep up with that. And that becomes a huge problem because that obviously, V pacing at 350 is not compatible with life. So we'll talk about how we get around this when we set up pacemakers. Any question about DDD pacing? Any comment on the PVARP? Yeah, so the PVARP is a post-ventricular atrial refractory period. Basically, what that means is that you do not want to deliver a paced rhythm shortly after you have delivered a paced rhythm. So again, if you have atrial activity that's going crazy, like atrial fib, you do not want to keep up pacing at the after you've just delivered a ventricular paced beat. Um, because you can get a P on you can ultimately put them into torsades from that because you have a R on T phenomenon. So that one's probably oh, it's Pune who asked that question. Yeah. So when you're doing pacer settings, we'll set that basically as a timed out period to allow for ventricular activation to happen. But it's not going to be protective against the atrial tachyarrhythmias completely because this is much shorter. And you can still pace at 250 or so because this is going to be a shorter interval. Did that answer your question, Pune? Cool. All right, great. So the next one we're going to chat about is going to be DDI. So this is a atrially sensed and paced capability. You have ventricular sensed and paced. Natalie's does cardiac irritation from a pacemaker lead itself ever lead to an arrhythmia? Um, So you can get PVCs with your lead itself, but it is, and you can certainly, and when you're doing these transvenous pacers, you can certainly have a lot of ectopy related to them. Usually it will calm down once it kind of nestles into a trabeculation. Your central line, certainly, if you're up in the atrium, you can cause some PACs. If you're really far down, you can get some PVCs if you're through the tricuspid valve. But irritation itself typically isn't an issue after you've got the lead secured in. All right. So the next set of pacing modes is called DDI that I wanted to cover. So again, this is a atrially sensed and paced, ventricular sensed and paced. However, the pacemaker will not track your atrial activity. So what does that actually mean or translate into? So when there's a sensed native atrial rate, the pacemaker is going to inhibit your atrial and ventricular output and allow the normal conduction to happen. If AV block develops, the ventricular pacing will occur at a programmed rate, but is not synchronized with the atrium. Okay. We'll try to go through examples because I think it'll be a little bit more clear if there's examples with it. So in the setting of sinus rhythm, let's say that we are DDI with a lower rate of 50. Let's say that you are in sinus rhythm with a rate of 60 beats per minute. Your pacemaker is going to be completely inhibited. So if you have sinus rhythm at a rate of 60, but you develop 2-to-1 AV block, the ventricular lead is not going to try to maintain AV synchrony here. It's just going to V pace at 50 beats per minute if that's the lower limit that you've set it at, and it is going to do that regardless of your atrial activity. So there's no AV synchrony when you're in this situation. The last example, so let's say your sinus bradycardia at 40 below your lower rate. Your pacemaker is then going to pace the atrium and the ventricle synchronously at a rate of 50. So if it has the option to pace both, it will. But if your atrial rate is above your rhythm, it's just going to pace at the set ventricular rate. This becomes very helpful. And it doesn't sound helpful, but it is. And the reason is because you don't have atrially tracking. So all of your atrial tachyarrhythmias are not going to be V-paced. So this becomes where mode switching comes in, and we'll talk a little bit more about that. So if somebody with DDD pacing goes into atrial fibrillation, you can then switch to a DDI where you ignore the atrial activity and so you're not trying to keep up with your atrial activity. So the ideal patient here is going to be your sinus bradycardia with or without AV node disease. Um, let me pull up my notes here really quick. So when you're looking at your diagram here, VA has to do with your ventricular to atrial interval. Your AV has to do with your atrioventricular interval. So again, no atrial activity or tracking, and it will not always try to synchronize. So in the setting of atrial fibrillation with RVR, it is not going to try to track with the atrium and maintain AV synchrony. It's just going to allow your AV node to inhibit it like it normally does in AFib with RVR. Lauren had a question here. So by inhibiting output, you mean from the pacemaker, not inhibiting cardiac. Yeah, that's correct. Yeah, we're not trying to inhibit cardiac signals. You're inhibiting output. This is the next three are a little bit challenging, and I'll be honest with you. I have to go through these multiple times in my head to try to keep them straight. But this is a helpful mode, and often what we will mode switch into when you have DDD pacing and you have an atrial tachyarrhythmia, meaning you're sensing an atrial rate that's way too fast. You're not going to try to keep up with it. So it's an opt out of your AV synchrony. All right, so the next one is going to be VDD pacing. So this is ventricular paced, atrial, and ventricular sensed, and either you're going to inhibit or track with the pacemaker in response to a sensed beat. So you do not have the ability to atrially pace here. All right, so you can sense everything, but you can't do anything about it from the atrial standpoint. So this is the ideal patient here is somebody who has normal sinus node function, but a diseased AV node, right? Because you don't have a slow atrial activity. You are just worried about the slow ventricular activity. So we don't really use this anymore because this is not going to maintain your AV synchrony. We now, if you have this, we're usually going to do DDD pacing, which maintains your AV synchrony and gets closer to physiologic pacing. The not ideal patient here is somebody who's sinus bradycardia, again, because you cannot maintain, you can't pace your atrium, and therefore if you're sinus bradycardia, you're going to be V pacing frequently and at a lower limit. So chronic RV pacing is unhealthy for the heart, and you're just V pacing at a lower limit. The benefit here, you can get away with this with one lead. So they make leads that have sensing capabilities in the atrium as it courses through the atria into the ventricle. So that is one of the benefits to having VDD pacing. Pune has another question here. Does DDD switch to DDI automatically when SVT happens? Yes. So you'll program in, hey, the atrial rate is going this fast. We're going to switch over to DDI. That's a setting that we put into the pacemaker. So again, kind of going VDD, my notes here. So again, you are only able to pace, you're only pacing your ventricle, okay? So you can see all of your atrial activity. It will try to maintain your AV synchrony, but if there's no atrial activity, you're just going to V-pace. So in the setting of sinus node disease, you're completely V-paced, and that's a problem if you have sinus node disease. So if you're in sinus rhythm, but you have AV block, you're going to be asensed V-paced, and you're going to maintain AV synchrony. And if you're in sinus rhythm, you're going to be completely inhibited. Any questions on that one? All right. And then DVI. So DVI is, we don't use this very often. You'll probably never see this, honestly. It's mostly of historical interest. It's one that we had before we had DDD pacing. So what this means is you have atrial and ventricular pacing capability, but you're only sensing your ventricle, and you're going to inhibit the pacemaker in the response to a sensed ventricular beat. So it's again, it's not common. You can't, you're not sensing your atrial activity, and that becomes a problem because you are unable to maintain your rate responsiveness in a chronostrically competent patient. And again, you can pace both, but you're only looking at the V. So this becomes a problem if you're starting to atrially pace, ventricular pace, but you're not paying attention to your atrial activity. you can initiate your atrial tachyarrhythmias, similar to your SVTs that are started with a PAC. Your ability to pace the atrium without recognizing when atrial activity has occurred can start a lot of these tachyarrhythmias. Again, now that we have the capability of sensing and pacing the atrium, we really don't use this setting very often because of this issue. If there's one mode that you don't remember from this talk, DVI is probably the one to forget. We don't use it very. Questions on that one? Asynchronous pacing. This is very simple. Asynchronous means you're not paying attention to anything that your heart is doing, and we're just delivering a paced rhythm regardless of what's happening. And you can set it to atrial pacing, ventricular pacing, or you can AV synchrony. But the pacemaker is not sensing any of the intrinsic cardiac activity. So that means you've got a lead in. I don't care what's happening or what I'm sensing. I'm just delivering a paced rhythm. This can be really helpful in the OR because, again, as I mentioned, you've got these sensing thresholds. So if electrocautery is going to be near your pacemaker and you're worried that your pacemaker might sense some of that electrocautery, turning this into a asynchronous pacing mode becomes very helpful. Because you'll look at the patient's native heart rate and you'll say, okay, we're going to pace them at 10 beats per minute above that, atrially pace them, and you don't have to worry about the pacemaker sensing any of the electrocautery. Potential problems with this. So you're going to have competition between your native and the paced rhythm. This becomes a problem, as I mentioned earlier, a P on T phenomenon where you have a paced impulse during a native T wave. This is kind of the vulnerable period, and this can lead to a lot of arrhythmias, including ventricular tachycardia. And again, you want to kind of pace faster than your atrial rate so that you don't have a native conduction happen in the OR, and then you develop this phenomenon. So when you're going to the OR, you turn off your sensing activity so your electrocautery doesn't cause any sensing issues. Pace faster so that you're avoiding this P on T phenomenon, and you should be okay. The reps will usually call us to help them. All right, a quick word about biventricular pacing. So what does this mean? So if we go back to what we think about, how does your heart normally conduct? So normally what happens is sinus node fires, it's received by the AV node, pierces through using the His bundle, and then it simultaneously travels down your left and right bundle so that your left side of your heart and the right side of the heart contracts simultaneously. That synchrony helps with optimal cardiac output. If you have a left bundle, for example, you can develop a cardiomyopathy just from having one bundle activated before the other. They believe it has to do with calcium recycling and calcium overload, but realistically, it's not fully worked out as to why that happens. The same thing can happen if you are chronically RV pacing. So if you are constantly pacing your right ventricle, that is not physiologic and it causes issues. You develop a cardiomyopathy. So we do what's called biventricular pacing. If you remember that chest x-ray that I showed where you have a coronary sinus lead, this allows for simultaneous LV and RV pacing. And this is an ideal thing for somebody who is going to require a lot of pacing or who has a cardiomyopathy from a left bundle branch block. So we've shown multiple trials have shown the benefit in heart failure, specifically for NYHA 2 to 3, in patients who are either chronically paced or have a wide complex on their ECG. These are kind of a summary of the trials based on their NYHA class. I'll briefly mention that they've also tried to do this for your narrow QRS complex called the ECHO CRT trial. Actually showed no benefit. So this is why our criteria and our guidelines say that it has to be a wide complex to be a candidate for cardiac resynchronization. So again, we use this really to simulate your physiologic pacing to the best of our ability. All right, so we'll go through a couple of problems and how our pacing modes can actually help us avoid some of these problems. So let's say we have a patient who's got sinus node dysfunction. They're programmed with an AAI set a lower rate of 50 beats per minute. But they've been living through, let's say, COVID. They're feeling all cooped up, and they've been obeying Dr. Acton's rules, and they've been staying home. But they decided that today is the day they're going to go out for a run, despite never doing that before. Person goes and they drive to Eden Park. They got a beautiful view. They start running, and about a half mile in, they collapse. So, what do you think happened here if this is the setting that they're set at? I think I've kind of mentioned this a couple of times, and you guys are probably scrambling to type an answer in here. So, most likely what happened is that your AAI pacing, you're not chronotropically competent. Okay, you have to have this setting called a rate modulation. What that means is that your pacemaker has the ability to sense activity. And it does it a couple of different ways. So vibration of the generator, your minute ventilation going up, if your impedance or the resistance through your leads are going up, it'll sense that as activity and it will bump up the paced rate from your lower rate to a higher rate. This allows for people who are exercising or doing things that are necessary to, you know, require a higher cardiac output to augment their rate to increase their cardiac output. So if you remember, your stroke volume times heart rate is cardiac output. So if you need cardiac output, this is a way to be able to do that. So that's going to be your fourth position here in your nomenclature. So let's go through another problem. So atrial fibrillation, flutter, and SVT are problematic for a lot of patients with pacemakers. So somebody who has DDD pacing and develops has paroxysmal atrial fibrillation. So let's say they're cruising along. Um, Danny asked if this is an essential, a standard feature. Yeah, usually people will have RRR, but it really depends on the pacing mode. Yeah, so if you don't have any sinus node disease, you really don't need RRR because if you're chronotropically competent, meaning that your sinus node's able to pick up in the event that you're exercising, then you really don't need rate responsiveness. Because if you are able to accommodate it, your exercise, sinus node's going to pick up, and you can use your other pacing modes to keep up if you have AV node disease. So let's say this person who's in sinus rhythm, all of a sudden they go into atrial fibrillation. So your atrially sensed rate is now 350 to 450 because you're in atrial fibrillation. So what normally happens in atrial fibrillation? So if you don't have a pacemaker, so what normally happens is your AV node can't accommodate that fast atrial rate. So that's why your patients with RVR, you know, their atrial rate's going 350 to 450 beats per minute, but their ventricular rate's only 150 when they're in RVR. That's because your AV node can't handle it. But when you're in a DDD setting, as I mentioned, the goal of DDD settings are to maintain AV synchrony at all cost. So that's going to try to keep up with your atrial rate and pace your ventricle at 350 to 450 beats per minute. That's a big problem. Okay, so why doesn't your ventricular rate get to the same rate as your atrial rate? As I mentioned, it's the AV node that typically will modulate that. So this is where mode switching becomes really important. So in dual pacing systems, the ventricle is going to be paced for every sensed atrial beat, but in AFib, that becomes a problematic issue because you're going to have V pacing at a one-to-one rate. Obviously, that's not good. So what it's going to do, you can reprogram this to stop your atrial tracking. Okay, so these are your examples of that, your DDI or DVI. So when that happens, when your atrial sensed rhythm goes above a certain threshold, you're going to switch over to a different mode so that you are not tracking your atrial. Any questions about that? All right, here's another problem that can come up. So let's say we've got a 60-year-old male underwent a single chamber pacemaker 5 years ago for intermittent second degree AV block. And his settings, you are a VVI pacing. The interrogation shortly after implantation showed only 5% pacing. And now he's coming to your clinic 5 years later, and he's complaining of fatigue, dizziness, and some throat fullness. An exam, you see Canon A waves, rails, and a holosystolic murmur that's heard at the apex. And your interrogation shows that he is now 99% V paced. So what's going on? Why is he having all these symptoms? Well, while you guys are thinking about that, there's a syndrome called pacemaker syndrome. So it's a phenomenon that we've correlated to AV dyssynchrony. So it's a result of the adverse hemodynamics associated with a normally functioning pacemaker system. but it results in a limitation in the ability to achieve your optimal functional status. So pacemaker syndrome, very nonspecific symptoms: malaise, fatigue, dyspnea, cough, orthopnea, and your exam can be hypotension, rails, but it's all related to not maintaining AV synchrony. So this is one of those patients that if you have progression of your AV node disease and you're frequently V-paced, you may want to consider upgrading this patient to a more physiologic form of pacing. That would be either with a biventricular pacing or with a dual chamber pacing so that you can track your atrial activity and maintain your AV synchrony. So keep that in mind if you have somebody who's frequently paced and is having odd symptoms. Their pacemaker might be causing this, and it might be related to their lack of physiologic pacing. So how do we choose the right pacemaker? So pacemakers are just like medications. You got to choose the right dose. You got to match what. Actually, Gene has a question here. Do the symptoms resolve after, or are they lasting? No, usually they get better after you've upgraded them to more physiologic pacing. It can be very difficult to diagnose because it's such non-specific thing. So oftentimes we'll upgrade them to see if it helps, and if it helps, great. If it doesn't, we look for other things. So choosing the right pacemaker. So this is kind of a big overview. I stole these right off of Up to Date, and there's a great article in Up to Date that Reza and I went through last year. But basically, you can start out, these are just algorithms here. Is there symptomatic or significant risk of bradycardia? No, then forget it. You don't need a pacemaker. But if they are, do you need AV sequential pacing? If the answer is no, then you can probably just get away with a VVI pacer or a VVIR if you need rate responsiveness. If you do need AV synchrony, you got to ask yourself, is your AV node competent or not? I'm sorry, your SA node competent or not? Okay. If it is, meaning that when you exercise, your sinus rate goes up an appropriate amount, you probably get away with DDD activity, meaning that you're going to sense when your atrial rate goes up, and then you'll pace when necessary to maintain one-to-one synchrony. If your AV conduction, meaning that when you are speeding up your sinus node, can you conduct up to a rate of 150 into the ventricle? Yes, then you can get away with AAI, which again we never do. But if you are not, if you've developed AV block when your sinus rhythm goes up above 150, then you might need to go DDD. We are usually, if you're on consults with us, we'll talk about which form of pacemaker you might need. Um, as internal medicine residents, you won't need to necessarily do this, but those of you going into cardiology will be talking more and more about what kind of pacemaker is necessary. And again, where is the disease, sinus node, AV node, and that should match the type of pacing system that you put in. All right, so if your sinus node is diseased, this is kind of what we do here. Is there evidence of impaired AV conduction, meaning AV block? Or if you're pacing or exercising them, do they develop any degree of AV block, or are they at risk for the development of AV block, meaning do they have sarcoid or some infiltrative cardiomyopathy that can be a problem? If the answer is no, you can probably just get away with an atrial pacemaker. If the answer is yes, and you need to maintain AV synchrony, AFib or something like that, then that can be either a dual chamber or ventricular pacer, depending on what the answer is for that. Similarly, for your AV nodal disease, this kind of takes you through here. So are they chronic atrial tachyarrhythmias? And you can't really get them out of it into a sinus rhythm. If the answer to that is yes, then you're not going to worry about atrial tracking. You're just going to be a ventricular pacemaker. But if the answer to that is no, you want to try to maintain AV synchrony, that's where you end up over here. So either your single lead atrial pacemaker or your dual chamber pacemaker. You don't care about AV synchrony, you end up with just a ventricular pacemaker. So spend some time looking at this. Try to match the when you're asking for a device, what you think they might need based upon where in the level of your conduction system the disease is located. I think we are just about out of time, and luckily that is close to the end of my talk. So I'm happy to take any questions if you want to type them in. I've got the chat screen open. I've got a couple minutes before I'm going to run off and do it. Yeah, be happy to answer any questions you guys have, and if enough time time to get all of them, just email me and try to work through them. All right, let's see here. Can you talk about the inpatient evaluation for the need of a pacemaker? I feel like we admit a lot of patients at the VA who have symptomatic bradycardia, either sinus or atrial flutter. It doesn't seem to happen inpatient. Yeah, oftentimes we'll end up doing these outpatient. So it becomes really challenging to know, are their symptoms truly related to bradycardia or not? And that's where the hangup usually is. There's systematic issues as well, like we just don't have a lot of EP docs that are there frequently, so that becomes an issue. But usually it has to do with, can we truly correlate their bradycardia to their symptoms? And that's usually what becomes the issue. Because if they're not symptomatic, again, your class ones are for mostly symptomatic bradycardia. And then it becomes a little bit lower in your class recommendation if you're having a hard time correlating the two. Can you briefly talk about bacteremia and infections? Um, sure. So if you've got an infection and you've got a device, most likely you've got a problem with that. We will try to usually image it to see if we can uh, document that this truly is infected. You can either do that with transthoracic. If that doesn't give you a good idea of your leads, you don't see any vegetations on there and you're still suspicious, a TEE can be helpful. One of the things that we're also doing now is you can actually order a cardiac PET scan as well. And if it lights up on your lead, it shouldn't. That would be concerning for infection. So I have a clinic patient right now that I actually sent for a cardiac PET because they've got a vegetation on their lead and has had prior bacteremia. And I don't know if this thing's active or what I need to do with those leads. So that can also be a good option for you if you're thinking this is chronic or some thrombus that's been there forever. But the recommendations are usually to take all the devices out if they're infected. The challenge is figuring out, is it truly infected or causing their problems. And how do you keep your hair looking so good during these hard times of quarantining? Great question, Dan. But that's hilarious. Um, the role of an ischemic evaluation in new sinus node dysfunction just based on clinical history. Um, Yeah, I mean, I think it's reasonable if they've got new sinus node disease. Again, your sinus node branch comes off of your right coronary artery. So if you're worried about new sinus node disease and they've got a good story or giving you any symptoms that would be concerning for it, I think an ischemic eval is very reasonable. All right. All right, guys. Well, happy to answer other questions by email or text me if you have questions.
Cool. Thanks for coming by. Thanks everyone for watching. And yeah, if you have more questions, let us know, and I'll email out this talk with the PowerPoint a little bit later today.
Cool. Thanks, Gene.
Thanks.